My philosophy, I would think you should give one surgery, the chance to declare its own outcome. So I'm just worried if both are done, it's too much stress on both ends of the spine. And then you don't really know what had done what.
Welcome back, every Bendy Body, to the Bendy Bodies Podcast with your host and founder, Dr. Linda Bluestein, the Hypermobility MD. Today, we will be talking with Dr. Petra Klinge about tethered cord syndrome. Tethered cord syndrome affects so many people with EDS, especially people with hypermobile EDS, so this is going to be a really important conversation. Dr. Klinge is a neurosurgeon with expertise in tethered cord syndrome, Chiari malformation, and related CSF disorders. Her research has focused on the failure of myodural bridges and defunct collagen that supports the aspects of CSF circulatory failure at the base of the skull. She has published on a novel concept of a spinal cord motion disorder that might explain and support occult neurosurgical pathologies associated with impaired CSF in Chiari malformation and occult tethering of the spinal cord and brainstem. Dr. Klinge has pioneered the pathophysiology and diagnosis of occult tethered cord, including clinical biomarkers for surgical intervention in tethered cord syndromes. I'm so excited about this conversation today because occult tethered cord, meaning that you cannot see it on imaging, is something that is really, really challenging. A lot of patients who are experiencing tethered cord type symptoms, they go in to get an evaluation, they get an MRI, and when the MRI is, quote, unremarkable, people think, oh, they clearly don't have tethered cord syndrome. But as Dr. Klinge is going to tell us, there's a lot of people who have occult tethered cord syndrome. So they have the symptoms of tethered cord, and they'll benefit from having surgery on their tethered cord, but you can't see evidence on the imaging. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. Well, I'm so excited to speak with Dr. Klinge today, and probably you don't remember, but we met in 2018 after you gave a presentation at the EDS Society conference in Baltimore, but I haven't seen you since then. So
yeah, time goes by, right? Yes.
Yeah.
Well, it would be great to see each other again sometime soon. That would be lovely.
Yes, absolutely. I'm so happy that you're here. We have so many questions that people have about tethered cord and your work specifically, and you've done such great research in this space. So I'm really happy that we were able to make this happen. So thank you so much. So can you start out by telling us how you became interested in occult tethered cord and the association with the Ehlers-Danlos syndromes?
Yes, so I have to say it's my first experience with occult tethered cord came from pediatric experience. So I came to the United States and to work here at Rhode Island Hospital in 2009. And around 2010, I was more and more involved in the pediatric hospital in Hasbro here. And then one of our GI doctors contacted me about a child with unexplained constipation and problems with bowel regulation. And then he said he had heard about tethered cord or even occult tethered cord, which can be the cause of some unexplained bowel and bladder issues in kids. And believe it or not, that's the time when I was hearing about it might be, a separate entity that is not really diagnosed with imaging, but more diagnosed clinically. So I saw that child and found out about some neurological signs in the legs, and there was also some back pain and leg pain. The MRI did not show anything. So the GI doctor and we offered the family the tethered cord surgery, the resection of the phylum. And that kid did so great and had such a great improvement, was even catching up with growing, the back pain and leg pain went away, and also the constipation. And then how things go in life, a second event like this happens. So I saw another child And then I became really interested in occult tethered cord, and I understood that this is really like an entity that needs to be taken seriously. And I read up some of the literature that was published in the early century. For example, Dr. Webby's work came to my attention, Monica Webby, who published 62 patients with tethered cord, occult tethered cord, kids that had improvement in bowel and bladder function. Fast forward, I presented the children that I treated on a conference where I met Dr. Henderson. And Dr. Henderson at that time, that was 2011 or 2012, had also started to look into tethered cord and Ehlers-Danlos syndromes and connective tissue disorders. So I learned from people that were already looking into people with connective tissue disorders that the problem with the tethering of the spinal cord might also be a very relevant problem for those folks. And then I said, okay, well, I developed some neurological criteria at the time that made me comfortable to diagnose, the triad and the neurological symptoms. And then I started to see people with connective tissue disorders. And I found some unique elements in how they present with tethered cord. And of course, then when you become more comfortable in diagnosing a problem, you keep looking at it. And of course, then you see the results. And the results were very favorable and very promising. And that has gotten me interested in occult tethered cord and EDS. And I saw more and more people and diagnosed it. And of course, my focus in medicine was always trying to explain things. I was never happy just treating them. So I wanted to understand, like what's happening here. And that's how I started to also look into, like understanding what the problem and the mechanisms are behind that.
Wonderful. And I should probably back up. And if you could explain for those who are maybe thinking, oh, this sounds really interesting, but I'm not sure what tethered cord is, much less occult tethered cord. If we could back up, and for those that maybe are not familiar with this topic, if you could explain what that is.
Sure. So tethered cord itself is in the broader spectrum, a problem where the spinal cord is unphysiologically under tension or stress and strain to anything that abnormally, fixates the spinal cord in the spinal canal. That could be many things, but the most common problem of tethered cord, and that's the one that we are, discussing today, is the problem with our embryonic tail. Or congenital tail. Let me explain it that way. When we are embryos, we all have a little tail, a real tail. And that tail is basically the extension of our spine. And it has like spinal cord and bone and cartilage. And then it helps us grow our legs as embryos. And when we are done with growing legs, the tail undergoes some what we call regression. So it ends up, like going back into the spinal canal. And then what we have is a leftover tail from that embryonic time. And it was once spinal cord, but it's now like some leftover spinal cord. And that tail actually connects our, mature spinal cord with the tailbone. So it's a leftover embryonic spinal cord. And a lot of things can go wrong during that process, where that tail goes into a regression. And if then the tail stays too tight or too thick or is just abnormally structured, it can cause, pulling, tension, stress and strain to the mature, the adult spinal cord or the, like a physiological spinal cord. And that can cause a lot of symptoms. The stress and the strain causes blood flow problem to the spinal cord, and that can cause weakness in the legs, fatigue, pain, not only in the legs, but also in the back, and of course, ultimately also problems with regulating the bowels and the bladder. So that is tethered cord. And that's not a new problem. Tethered cord has been, like the first reports on tethered cord and, like abnormal or tight phylum go back into the 60s. Now there are reports, like from, Canadian neurosurgeons, like 70 years ago, where they already like, without even having an imaging, they had patients with leg symptoms, leg weakness, bladder and bowel symptoms, where they actually did explorative surgery. They opened up the spine to see what's happening here. And then they found like this embryonic tail being too short or too tight or too thick. So that was pioneering surgery. So tethered cord is not new. But what is more like that pioneering, or more like a recent, and in the realm of medicine, more recent thing is the understanding that it can actually, like really be occult, even with our modern, ways to image the spinal cord and the spine. Of course, when MRI became available, of course, then all of a sudden you could see, like the stretched spinal cord. You could see that the tail was thickened, and then you would say, oh, this is tethered cord. So imaging was eventually available, and allowed us to diagnose it. But then, all of a sudden a new box opened, and the new box was like patient presenting with all these symptoms, which are classical tethered cord symptoms, but yet you don't see the tethered cord in the MRI. And it was actually Jerry Oakes and his team at the end of the last century that had then coined the term, like it might just be occult. Jerry Oakes is a very renowned neurosurgeon, back then a pediatric neurosurgeon. And then we understand that it can be occult, and occult means like you don't see anything in the MRI that is suggestive of tethered cord. So radiographically hidden, but yet you still have it because your symptoms tell you that you have it.
Okay, that's such a wonderful explanation. Thank you for that. And it sounds like you've already described a lot of the potential symptoms that people can present with. Do you find, too, that the presentations are quite variable as well?
That is true. When I started to, straighten my own mind and be mindful that I really understanding that the MRI is not my partner anymore, the MRI is not helping me, but I still didn't want to, like, like it shouldn't be a shot in the dark, right? If I can say it that way. So what I'm trying to say is, at the beginning, I had taken, the classical criteria that were available to find out about tethered cord, which were, or which are still, bladder incontinence, either frequency or urgency. As I said, leg pain, often aches, and pain that fluctuates, in different parts of the leg. So it's not like a sciatica pain that goes, down to the toe or to the heel. It's a pain where people say, it's in my upper leg, but then sometimes it goes down into my other leg, or it fluctuates from left to right. So it's more like a nondescript pain, and definitely not a dermatome, like not a certain area every day. It's different areas. So variation. And then, of course, lower back pain of achy nature. So, but then when I saw people with this type of presentation, they were explaining to me all other sets of symptoms, like shoulder pain, arm numbness, tingling, like loss of penmanship, often like problems with the grip, or like problems opening a jar. And patients also had like pulling sensation in the neck, and then sometimes also chest tightness. They felt like they are in a tight onesie, or they are, like tightened up. And I said, and then I said, well, I'm not sure how I can explain those symptoms, because nothing in your, you know, uh, MRI shows that you have neck problems or thoracic spine problems. And then I learned that after surgery, after tethered cord surgery, that I was doing for the symptoms of back pain and leg pain, those symptoms went away as well. And not always, though. I don't want to over deliver, but that was much to my surprise. So I learned, okay, well, maybe, and I saw it again and again. I had people that said, oh, I have this low back pain. Yeah, there was tethered cord. And then neck pain had gotten better. And so then I had understood, okay, it must be that against the classical thinking that the tail problem is only causing problems to the waist down, it might also cause problems to the waist up. And then, of course, I collected those symptoms and had to understand that tethered cord can also cause, problems to the upper extremities and upper spine areas. And then it wasn't until our research that we had published in 2022 where we were understanding, the stress and the strain that the phylum, that little tail causes to our spinal cord is not only affecting the lower spinal cord. Our biodynamic studies that we did in the Brown lab, where we were, mimicking the stress and the strain that the phylum does into the body, it might actually also propagate the stress to more, uh, further away areas of the spinal cord, which explains, the upper body problems. So I understood that there is a spectrum of symptoms that can affect the entire spine.
Yeah, that's fascinating. So it sounds like, given this complex picture of symptoms and the fact that imaging is not always helpful, making the diagnosis seems like it could be quite challenging. Sometimes it's acquired, right? And sometimes it's congenital, right? Is that correct? So, and
yes.
So it seems like actually making the diagnosis can be pretty tricky.
Yes, that is true. And there was a time where it was hard at the beginning because, as you said, I was hearing like a set of symptoms that were classically not attributed to tethered cord, but yet I had to take them into my account because I had to find out, is it or is it not tethered cord, and how would all these other symptoms speak for or against it. But what I wanted to say is, uh, then, like with anything in medicine, uh, is we wanted to have some objective criteria. Certainly, what was very like how can I say it, comforting for me as a doctor is that I heard some problems again and again. So I knew there is something unique to tethered cord that I can trust. For example, pulling sensation, shoulder pain, tightness in the chest. So I believed, that certain reporting that I got from people, the, well, can be tethered cord and most likely is tethered cord. So I got comfort in listening to people and understanding what they're dealing with, and there was like some like common element to it. But of course, to your point, is then of course I was trying to see, is there anything like objective that the doctor that the doctor finds in the exam. Of course, as you know, classically people were relying on the bladder study, the urodynamic study, and we can talk about it in a little bit, where you wanted to see like a neurological dysfunction of the bladder. But I learned that this is not always helpful. I had kids and adults where they had all the symptoms, but the bladder study was not showing me a neurological problem. And I said, well, I'm not going to walk away from that person. So all of a sudden, I had this patient with the classical, like symptoms, but the bladder study was not helpful. The bladder study did not show me the neurological problem that I needed to see as like a supporting criteria or a supporting diagnostic test. So then I said, okay, it might be that something in the neurological exam is, like telling me if there's a problem with tethering of the spinal cord. And then I was focusing on the neurological exam, and I was thinking at what would it be in the neurological exam that is indicative of spinal cord stress and strain. And of course, it would be, like a motor neuron dysfunction, because the motor neurons, they are the ones that, like travel through our spinal cord. So I was looking at like spasticity, like increased tone and tightness in the legs, a clonus maybe, which is a sign of, like stress and strain, like of the cord, like an upper, like motor neuron dysfunction or a long tract sign. Basically, like signs of spinal cord stretch. And clonus or increased tone in the legs, hyperreflexia in the lower extremities. And this was right on it. I was able to find these criteria in the patients that most classically presented with the signs and the symptoms. And then I saw that these findings are actually also very important diagnostic criteria to support tethered cord and also to predict the success of shunt surgery. And that was the paper that we published actually last year, after many years in the making. It took us like probably 10 years to like acquire robust evidence for that neurological finding and those neurological criteria. And we also found that this exam adds like 3 points to like a scale we developed that implements the patient-reported symptoms and the diagnostic finding on the neurological exam, and that is also able to predict the success of the surgery. So basically, in the meantime, I would say we have our objective diagnostic criteria that help us to more to establish not only the surgical candidacy but also the diagnosis with more confidence.
Which is so important. If you're doing surgery, you want to know with the best degree that you can if the surgery is likely to be successful. So that's really an important study. Yeah.
Yeah. And the scale still needs to be refined. As you might know, Dr. Bluestein, this is an open access publication. So everyone can read it, and it shows, the criteria and the 15 items that we developed as like diagnostic marker or biomarker for this tethered cord syndrome, and also for establishing the diagnosis and the surgical indication. It's still in the like in the it's baby steps, and it's still like the first attempt to validate this syndrome. It's still a long way to go. That scale has to be refined, and I would not say that this is all like straightened out or something that we should take as a completed work. It's work in progress, but this is the first attempt to really like put some diagnostic criteria that are reliable in this regard.
And we will definitely link that in the show notes so people can find that paper easily.
Yes, I'm very happy to send you the link afterwards in the email.
Yeah, because that's really important. So thank you for that. And people who have one of the Ehlers-Danlos syndromes, or if they have mast cell activation syndrome or dysautonomia, why are they? Which populations are at increased risk of having tethered cord syndrome, and why would that be? So yeah, any connective tissue disorder, but maybe more specifically EDS, why people with those conditions, and I don't know if it would apply for HSD also or not, but are you seeing those comorbidities more commonly in your tethered cord patients? And if so, why do you think that is?
Yeah. So of course, based on our findings, and it is likely that people with hypermobile EDS are at higher risk of developing tethered cord syndrome. And it might also be also acquired here. I have to assume that based on our findings, and I will comment on those in a little bit, there's also an acquired component in people with hypermobile EDS. and not necessarily a congenital component of tethered cord, because it is probably the connective tissue or the collagen problem itself. So what we found when we looked at the histology of the phylum. Let me track back a little bit. When you do the surgery, you usually like resect a piece of that phylum, aka embryonic tail. And we always examine this piece of the specimen histologically. So it dawned on me that I should also look at the collagen in the phylum. And so we started to look at the collagen integrity, because the phylum is a tissue that consists of collagen. And that's been described, in old pathological and anatomical studies. And I said, why should I not look at the collagen? So here I have a patient population that have a collagen dysfunction. They all have, or most of them, or many of them, present with tethered cord symptoms. So let's look at the collagen. So then in 2014, 2015, I started to do electron microscopy studies, and we looked at the collagen and did find the same collagen abnormality that you actually found in skin biopsies in people with classical or, hypermobile EDS or other forms of EDS. And the collagen had the same abnormality. The disintegration of the collagen structure, abnormal shaped fibrils, disintegrated, chopped up collagen, spiraled collagen. I don't have to repeat those findings. And these collagen abnormalities were mainly found in people with hypermobile EDS and not in the patients that did not have EDS. So that was specifically or more or less specifically a finding in people with hypermobile EDS. So basically the collagen dysfunction that you deal with when you have hypermobile EDS is also happening in your phylum, and that makes the phylum relatively stiff and less elastic, and that's why there is a higher prevalence or a risk you having tethered cord symptoms because you have hypermobile EDS, and your collagen dysfunction also, is happening in your phylum. That is one reason why people with hypermobile EDS or with connective tissue disorder are at risk of having, tethered cord, because the phylum is dysfunctional based on the collagen deficiency. And I believe, or would explain it, that if you are hypermobile, you have more range of motion in your spine. And that's also been described in some studies. That and then if you have a relatively stiff phylum, it doesn't matter, like even if the phylum is not, like that stiff, but the phylum might be just too much for your hypermobile spine to even be there. What I'm basically saying, that sounds like very pioneering, but you might just having a phylum with a hypermobile spine might be too much, because the phylum just being there as an anchor might anchor your spinal cord too much, because your spine is relatively too hypermobile. So it might mainly, the hypermobility might be the problem that makes you having a phylum, being a problem, if that makes sense.
So it's like a mismatch between the amount of motion in the actual spine and the amount of motion in the spinal cord, which is bathing in CSF, cerebral spinal fluid. Is that what, am I hearing you correctly about that?
Exactly. You just put it in better words. Thank you.
Okay. Well, wanted to make sure I understood that. So, okay. That's fascinating.
Absolutely.
Fascinating. And you've also done studies on mast cells in the phylum as well, correct?
Yes, and I just want to give the person that encouraged me to do so the right credits. It was basically Dr. Maitland and also Dr. Chopra, who thought that because neuroinflammation is also a problem in people with connective tissue disorders, and Dr. Maitland had always, been concerned that like mast cells and other inflammatory cells affect the nervous system and the spinal cord system. So they asked me this is a specimen that we have, right? And the phylum is, as I told earlier, embryonic spinal cord. So Dr. Maitland asked me, can you see whether you find inflammatory cells in the phylum, and particularly mast cells, because that would be a indicator that really like inflammatory processes in the nervous system are truly happening. So that's what we started to do. And we looked at the mast cells, we stained them. There's a certain immunostaining for activated mast cells. These are the mast cells that actually also cause trouble in mast cell activation disorder. So I learned a lot. And yes, and we did find those mast cells, not always, not with everyone. And I did not see, if your next question is that if you found a correlation with mast cell disorder, not really. I had people that had like a significant mast cell disorder, and I did not see a mast cell in the phylum. And then people had at least no known or established diagnosis of mast cell disorder, and then I found a lot of mast cells in the phylum. So I hadn't been able to establish a correlation here, but yes, in people with hypermobile EDS and with EDS, there was a higher prevalence of mast cells and inflammatory cells in the phylum, indicating that either it is, a sign of neuroinflammation that is also reflecting in the phylum, or it is truly a separate thing, from the mechanical stress and strain that happens in that challenged phylum. It might also be a secondary problem in the phylum, that inflammation is just a sign of the mechanical overuse of the phylum. And like a tendon, like a elbow tendon, eventually from mechanical overuse becomes inflamed, right? And if you go into the tendon literature, like mechanically overused tendons do have inflammatory cells. So we came up with the concept of, the phylum could just be the tendon of the spinal cord, because it's an anchoring ligament, it anchors the spinal cord to the tailbone. It's like a tendon, because a tendon anchors the muscle to the joint, right? So we tried to, really look into other areas. We were trying to get knowledge from other fields, because there's nothing we had nothing.
Yeah.
To understand this. So I went into tendon literature. I almost, I turned around all the orthopedic literature on tendon disruption, tendon failure, and learned a lot. And the phylum did show, not only the abnormal collagen, but also the inflammation and calcification even. We found calcifications in the phylum, more in adults, not so in kids. And here you can make the point, okay, the adult has suffered longer from tethered cord. And eventually, if there's inflammation, along with inflammation goes calcium buildup. And so the calcium in the phylum is also a sign of mechanical overuse. So that is also a validating, pathology, showing that there might really be not only a congenital problem with the tethered cord. The calcium buildup is definitely not anything that you were born with. Calcium buildup is acquired. So when I saw all these calcium deposits in the phylum, I had more or less the proof there's got to be like an acquired component here that proves that the overuse of the phylum, due to using it in term while you are bending and twisting and living your life is a sign of acquired or secondary tethering that happens with probably hypermobility or other overuses of the spine.
That is really fascinating, and I've never thought of the phylum as being like a tendon before, but that's super, super interesting. We are going to take a quick break, and when we come back, we're going to talk more specifically about surgery for tethered cord syndrome and what treatment options are. So we'll be right back. This episode of the Bendy Bodies Podcast is brought to you by EDS Guardians, paying it forward in the Ehlers-Danlos syndromes community, patient to patient for the common good. I am proud to serve on the inaugural board of directors for EDS Guardians, a small charity with a big mission and a big heart. Now seeking donors, volunteers, and partners. Patient advocacy and support programs available now. Travel grants launching in 2025. Learn more, shop for a cause at their swag store, and join the revolution at edsguardians.org. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. So we're back with Dr. Klinge and having a great conversation about tethered cord syndrome. And I'm so curious to ask, based on what you were just saying about calcium buildup, what about adhesive arachnoiditis or arachnoiditis? Is that, when you're talking about the calcium buildup, is that separate? Is that somehow related?
It is a very good question. Sometimes in tethered cord surgery, when we are exposing the phylum, sometimes we do see arachnoid adhesions around the nerves. I'm talking about arachnoid adhesions. Let me table the arachnoiditis or adhesive arachnoiditis for now.
Sure.
Associate with the phylum, and more that I would expect. So I came to the conclusion that it is probably also a consequence of the tethering due to the inflammatory processes that can happen in the phylum, along with the calcium buildup, that also the arachnoid becomes inflamed, secondary to the inflammatory processes that are going on in the phylum. And we see that not only in adults, but sometimes also in children. I still wouldn't call it adhesive arachnoiditis, but it might be, that eventually untreated tethered cord can cause, also inflammatory processes in the arachnoid. And that might lead eventually to adhesive arachnoiditis. That we don't know for sure. I would say, in all honesty, all I can say for now, that the surgical findings of arachnoid adhesions and arachnoid thickening, more often than not in tethered cord surgery, are very highly suspicious of inflammatory process that are associated with the tethering due to inflammatory processes there.
And are there options for treatment for tethered cord syndrome besides surgery?
Yes, some of them are more established, and some of them are less established, and some of them are still up. The jury is still out there. Of course, we always felt that physical therapy can help a great deal. There are certainly specific, elements in physical therapy where you can release, tension in the paraspinous ligaments, manual therapy, or craniosacral therapy, where you can help spinal fluid, movements, and you can relax the dura. So those certainly can also relax, any tension or stress and strain on the neural elements within the spine. And here, I think physical therapists with specific knowledge can help a lot. Of course, sometimes it's slowing down the process, but sometimes also it can help with a lot of improvement. The other things that are out there now, and I'd like to mention them to pay credit to the providers that offer that treatment, but I don't know yet whether this would eventually, really modify the tethered cord symptoms, are like microcurrent therapy or shockwave therapy. As you know, these are treatments that try to release, scars or release tension in ligaments. We still have, to get more evidence on those treatments, but those might also be treatments that are, either helping after the surgery, or might be also be something that you can probably do before surgery in order to see if this releasing or if this alleviating some of the tension. But this is treatment that we are looking into right now. And but I don't know yet, if this is like a true viable alternative to the surgical intervention.
Yeah, no, that makes a lot of sense. And when it comes to some of those things, probably the risks are pretty low. So it's worth trying to see if there is any benefit because, of course, surgery is a big deal, right? So it's, if you can try something that's pretty low risk, it might be, worthwhile, whereas something that's more risky might not be a good idea. So until we have a lot more evidence for that particular thing.
Yeah, that is true. The one thing, of course, I have to say as a surgeon, if you don't mind, is, of course, if symptoms are progressing quickly, of course, then you, of course, worry about because sometimes, even though tethered cord usually is a very, slow progressing, problem, but every once in a while you see people within 6 months or 3 months showing rapid decline. Of course, then probably you should seriously be looking into surgical intervention. But of course, people that had said that are more lingering or slowly progressing, and we have the luxury to monitor, then it's certainly worthwhile to try these techniques to see whether there is something that can improve you. Absolutely. And particularly those people where even from a surgical perspective, where we would say, hey, you are not that symptomatic right now, or you're not that quickly progressing, you are somehow still managing your symptoms. Why don't we wait another 6 months to see how you're doing and get more evidence whether you are truly progressing? And then, of course, then surgery is a reasonable option, if that makes sense.
Yeah, no, that totally makes sense. And that's an extremely important point. So thank you for stressing that because, definitely I know of patients in my own practice where things seem to be kind of smoldering along for quite a while. And like you said, other people where things are accelerating pretty quickly. So that's a really, really important distinction. And speaking of things that can accelerate fairly quickly, a lot of people who are hypermobile throughout their spine and have tethered cord seem like they might also have craniocervical instability. And in terms of the sequence of what surgery to do first or how they might impact each other. What are your thoughts about somebody who has craniocervical instability or upper cervical instability and tethered cord? I know there's probably different philosophies in terms of which surgery should be done first or how one surgery might impact the outcome of the other. But what are your thoughts on that?
Yeah, that is certainly a very important question, no doubt, but also the most difficult, or one of the most difficult questions, because it has yet to be determined what the sequence is here. So let me give you my thoughts. If it's again the symptoms, if the symptoms in the lower extremities or the tethered cord symptoms, let's say this, are highly relevant for the person and affecting the quality of life, in a very relevant way, I would favor, even though there are also craniocervical instability symptoms, I understand. So we're talking about the person that has both. But if the tethered cord symptoms are relevant enough for the person to say it's affecting the quality of life, I would suggest that the tethered cord release should be prioritized over the fusion, because there is a certain chance that maybe due to improved biodynamic stability in the spine with improved paraspinal muscle strength, that eventually the phylum release should give your muscles, that you would also have some benefit for your upper spine dynamics, and you might actually stop also the progression of the craniocervical instability. But that is only if your tethered cord symptoms are relevant enough in terms of how they affect your quality of life and your quality of well-being and function. I would say it certainly for now is a 50-50. If people say, oh, yay, you're treating my craniocervic instability as well, I would say, let's not get too excited about it. I'm just saying, I would favor the tethered cord, and then we can always see if you really need instability. But of course, a person that has threatening symptoms from the craniocervical instability side, let's say swallowing problems, a lot of cranial nerve deficits are significant, like instability with a neck collar, not being able to sustain any activity without it. I think probably, like the craniocervical problem is more relevant, and the tethered cord might even make it worse because we are disturbing like certain balance in the spine. So it's a very tricky answer because it's so unique. So I do it basically, make the decision on the individual basis. But I always say that tethered cord release, at least, improves the anchoring of the spine and improves the function of the paraspinous muscles. And that should be beneficial for the dynamics of the spine. So I'm always hoping that it will also help like stabilizing other parts of the spine. But on the bottom line, unfortunately, we have not worked out a certain pathway where we have a yes and no decision tree to favor one or the other. So it's unfortunately still a big problem. And the problem is also then if the symptoms of craniocervical instability progress, it affects, of course, also the outcome of your tethered cord surgery, because then it also mimics, a lot of, lower extremity symptoms, because it's then still causing stress and strain to the spinal cord.
Yeah, it's complicated, right?
Yes, that is complicated.
Yeah, each person's presentation is so unique, and so trying to figure that out. And isn't it true that there are some surgeons who actually have done both surgeries at the same time? I think I've heard that. I've never had a patient do that. But
yeah, there are occasionally, like surgeons that entertain both, which is not unreasonable. My personal opinion, if I'm allowed to share that here,
yes,
is that,
of course.
I always think that, of course, this is, everything is connected. We know that, of course, when we talk about connective tissue disorders. But I also want to say that the spine is one thing, right? So tethered cord and CCI, Chiari, they are connected. But in my opinion and in my philosophy, I would think you should give one surgery, the chance to declare its own outcome. So I'm just worried if both are done, it's too much stress on both ends of the spine. And then you don't really know what had done what. So I always try to convince my patient, let's do one thing, let's do the tethered cord, and let's wait at least 3 months, let the body adjust, see what it does, because we would never understand what was really like the tethered cord problem in your body. That is also important for future reference, for future guidance. If we had done both and you're not good, then we don't know, have we stressed your spinal cord too much? Have we, like caused too much stress for the upper and lower spinal cord? So I think, in my opinion, there's always one measure that should be done, and you should have the option to allow to see what is the outcome of that, because that tells you also something about your body, right? That tells you about what was really going on. That gives you some answers. And otherwise, we give away the answer that we can get from one intervention. Is it a good answer or bad answer? But it is an answer that we need.
Yeah, that makes a lot of sense to me. I think that seems like if it was me and I was, being recommended to have either one or both surgeries, but I think doing one at a time seems very, very logical. And of course, there's potential complications with any surgery, but especially with these neurosurgeries that, and in people who have connective tissue disorders. What potential complications should people be aware of for tethered cord surgery?
Yeah, so I think and I keep saying this now, again and again when I see patients that I think with tethered cord is considered or should be considered as a controlled surgery, meaning that the steps are well defined and you should be able to even control, like the closure of the dura and minimize the risk of a CSF leak. So the technique that we have applied in the past in order to avoid a spinal fluid leak is taking some fat from underneath the skin or from the fascia during the same approach and putting that fat on the dura to seal it. After you close the dura, you put that fat on there, and that is a great seal. So I really haven't seen a CSF leak for a long time. So my message is you should be able to control the risk of a CSF leak. So in that sounds arrogant, but I would say in my, practice, I'm not so worried about a CSF leak because you can control it with that technique. The main risk that we should be worried about is wound healing problems, particularly with the connective tissue problem. Sometimes there's wound dehiscence or allergic reaction to suture material. So wound healing problems, dehiscence and keloid, which can be dealt with, but it sometimes can certainly be very stressful, to revise a wound. So I would say with hypermobile EDS and connective tissue disorders, in about, 7% or 10% of people, we see issues with wound healing that not always needs revision, but it can just be very inconvenient or a rough experience and then sometimes we have to revise the wound. The one thing that that is under the radar is the retethering rate. I have two messages here. The retethering is from doing the surgery, actually, because you have to open the dura and you create a little scar. Even though we remove that phylum, the nerves can retether to the surgical scar. That is the nature of the surgery. You open the dura, you open the arachnoid layer, you take the phylum out, and the nerves can retether to the dura arachnoid layer. This chance is based on our own institutional statistics, and we hopefully are able to publish that as well soon, are 7%. Not that I like that number, to be quite honest, and I'm happy to share my concern with that is because you ideally want to have all complications less than 3%, but that is of course in the ideal world. So of course, microsurgery becoming smaller and smaller with your incisions and openings of the dura might eventually, minimize that risk, but it's still a problem because what happens is that the symptoms then come back after 6 months or a year. Usually what I do a prone MRI because a prone MRI would show the attachment of the nerves to the surgical site. And then you have to do a second surgery, which is also a reasonable thing to do. But of course, it's a second surgery. So to answer your question, let me say it that way. Immediate surgical complications can be well controlled. The wound healing, we sometimes utilize plastic surgery to help with closure. The CSF leak can be controlled with a graft or just being mindful that, the dura needs to be closed meticulously. And anesthesia is an hour and a half. That is not a major thing. If the anesthesiologist has a protocol to protect the mast cells. So I think all the perioperative and surgical things in an experienced hand, and in an experienced team can be managed quite well. What is the main concern is the long term. One long term is the retethering, which I gave you statistics and the matter around that. It can be dealt with another surgery, but of course, long term is how long are we helping people with a tethered cord surgery? Is it for 2 years? Is it for 3 years? Is for 5 years? So we don't have the long-term outcome. So what I'm basically saying, what we all have to be mindful is, what are we expecting? So if for now, as a doctor, I cannot even tell you what the tethered cord surgery is going to bring you in 10 years, or in 5 years. I can tell you that we are looking into 1 year or 2 year outcome, and those that improve or have benefit from surgery do improve, in this time span. But we are not really looking into 3-year outcome, 4-year outcome, 5-year outcome, and we don't know how people functionally do at that time. So basically, we should all be now focusing on really looking at long-term outcomes. And we are currently evaluating our 5-year outcomes as well in our institution, looking back, and hopefully I will come up with some understanding here, which is tricky because other comorbidities play into it. Then you have another surgery, you have a fusion, and then you have certainly issues with mast cells or dysautonomia. So it's a big thing to look at because of all the other comorbidities. So I don't have a good answer right now, but my main concern is what is this surgery helping long term? Is it really alleviating all the other issues that a person, particularly with connective tissue disorder, is dealing with? But people do report, that it has helped and to the body to feel better, even if it's not a cure, but to have some alleviation. And any alleviation, any gain in function often helps you to concentrate and focus on other health issues.
And I appreciate your transparency about the retethering rate. As an anesthesiologist, I used to always chuckle with, some surgeons the blood loss was always less than 10 mLs, right? And others, you knew were really honest, and they would say it was, 100, 150, 250, whatever it was. You knew that you could trust them. And some surgeons would say, I've got another 10 minutes. And others would say, I've got, another 10 minutes, and it would be actually a real 10 minutes. So I appreciate you being totally transparent about that because, surgery always, confers, everything that we do confers risk. So that's really important. And of course, looking at 5-year follow-up is tricky because you lose people to follow-up, right? They move, they don't respond to messages or whatever. So I don't think most people realize how difficult it is to actually follow people 5 years later and get data from that.
Yeah, it is. And I have to, thank our research team. We have graduate and undergraduate students and medical students that try to find people and contact them to get results. So we are really working hard on it. But yes, of course, you don't get the whole set of information, and it is true that this is a difficult task. But at least it's important to look at it. Yep.
And we're going to need to wrap up because I know that you're really busy, and I really appreciate you taking the time to chat with me. I know one of the things that people wanted to know about is if you had tips for recovering from tethered cord surgery.
Yes. So tips is, first of all, to not be too careful. That sounds like the opposite of what you think I would say, Of course, the instructions are always don't bend, don't twist, don't lift. I would not be... so it's probably good to move your body natural. What I have started, because I learned that the people that are too careful are moving in the wrong direction. Because I guess with not using your body, you create more muscle tightness and muscle spasm. So basically, you should not, of course, do major physical activity, but try to right away, walk, sit, do minor chores, to really use your body naturally. Try to bend and twist in the way that the body allows you. So that is my advice for people, to not be too scared. And also to really not be too scared about a CSF leak, because really, I think this is not really the point that that I worry about. It's more like the retethering, as I said, and also here I feel like the more naturally you move your body. So do some bending, do some things, challenge your body a little bit, so you get your spine in motion right away, if that makes sense. And the other thing is to also understand that it takes time for the body to adjust to the surgery. So if there are new symptoms like some bending, some tingling, some twitching, or like some the weakness that you hadn't had before, it's okay. It's the adjustment of the spine. So be prepared to have some new, interesting feelings in your body that might be a little scary, but embrace them. Say, oh, that is just what's happening in my body, and be embrace these symptoms. It's better for like for your body to accept those than to fight those, and then start to use your body as much as you can. Of course, I understand there are people that are in pain for other issues or still have some back pain that prevents you from doing things, but it's important, like to do as much as you can, and then of course get the help of a physical therapist if there's still significant back pain and back spasm. Physical therapy can help there quite a bit. It's that's like all I'd like to say, because people are of course mindful and know their body better than any doctor knows it, but I sometimes see that people are too worried about that you can hurt like your surgical site with little movements. No, you actually have to trust your the healing and use your body in a natural way as much as you can.
That seems like a very
Because
reasonable.
you have to accomplish confidence,
Right. Yes. Confidence, I think, is a very big thing. Having confidence in your body. And I know for me, having hypermobile EDS, that definitely is something that happened. I lost confidence in my body, and it was a while before I got my pain under control and regained that confidence. So that is a very important thing. And in terms of the symptoms, what they were saying, if you have new symptoms, there probably are some like red flag symptoms that you'd say, that you need to contact your neurosurgeon about. So you were saying you might have some new tingling or some, some pain here and there. Are there certain symptoms that you're like, well, wait, if you have these symptoms, you need to get that checked out? Are there any
so
like
certainly,
that?
so the symptoms that you can have is like twitching, jelly feeling in the legs, like weakness and numbness, tingling. But what is certainly should not happen is if you, like feel that your legs are becoming weaker and weaker, so that you are, not able to ambulate. So that is certainly a red flag. And then the other red flag is a significant, like intolerance to sit up, significant headaches that can be suggestive, of course, of a CSF leak, like spinal leak symptoms. And certainly, like pain that puts you in agony. So usually, of course, that can also have other reasons. Lack of appropriate pain management, or just you being like very sensitive to what just had been done with the surgery, but like significant back pain that is not managed by any like physical therapy intervention or pain management, significant loss of leg function, and a lot of spinal headaches. I'd like to say some people have spinal headaches from the loss of the spinal fluid during the surgery, because we are losing like, I would say, like 50 cc's of spinal fluid during the surgery while fishing out the phylum, So some people have like prolonged CSF leak symptoms, but it's not a leak, it's just the loss of the spinal fluid during the surgery. I always tell that, and my team tells that the patient, while they're in hospital, to remind them, look, it's not always that you have a leak. We have, really such a low CSF leak rate. Please don't forget you lost spinal fluid during the surgery. That can also be a problem. But of course, if that lasts past a week or so, then it might be something to consider. And then I would do a lumbar MRI. So if people telling me, Dr. Klinge, I'm sorry, I'm not walking in the right direction. I'm walking in the other way. My legs are giving out on me. I cannot stand my pain. I'm in bed all day, and my head is killing me. Then I do a lumbar MRI to see if there's a surgical complication or what's going on.
And I think
of
it's
course,
important.
urinary retention, Yeah. If you had been able to empty your bladder before, or at least had a decent bladder function, and then afterwards you can't, then of course there might be a neurological thing that you should be looking at.
Okay. And we were always regenerating CSF, right? So it's, even though you lose it in the surgery, that's why you're saying like a week, to give us a little bit of time to be making new CSF. So, okay.
Yeah, absolutely.
Excellent. So I always like to end every episode with a hypermobility hack. So some kind of a quick win for people. Do you happen to have something that you can share with the listeners?
Are you meaning like in terms of like the health or anything?
Anything for people who are part of this, triad of EDS, mast cell activation syndrome, POTS, they may have tethered cord syndrome. Of course, this episode is specifically about tethered cord syndrome. So something relative to that would be great. But anything that, somebody might not already be aware of that might be something that they could try or that they might find helpful.
I think, as a researcher, let me say this. What I felt, and much to my regret, is that people feel dismissed, right? And of course, now there are groups that support each other, but you still feel alone, in this world where there are many uncertainties and things going on, like where you hear many opinions. I would like to say you will, keep trust in your body. I learned, like that people are right about their body. They're right about what they're feeling, Don't let any doctor turn you down. Believe in what your body is telling you. Believe in your symptoms, and then read. That's why I did all my publications, or most of my publications, as open access. Read, because you find your answers in, like research that has been published. There also is, for example, the publication that is also public from the NASEM work, the National Institute of Sciences, where we discussed, neurological issues in relation to tethered cord and other and Chiari and connective tissue disorders. So read those things, and you will already feel better right away because you feel validated, So I'm happy to give you the links. So the NASAM, like report about like neurological issues with connective tissue disorders is open access. Some of our publications open access. So believe your symptoms. Trust your symptoms. You are right about how you feel, but look at like what's out there also to validate your symptoms. And when you read it, you will already feel better about being validated, and then you can have time to think about your next steps.
Okay, thank you for that. That's really helpful. And I'm so grateful to you for joining us today. The final thing before we go, can you let people know where they can find you, and also if you're working on any special research projects right now, or anything else that you wanted to share?
Yeah, so I don't have social media. So the best way to find me is, through my email, my brown email. If there are questions. So I guess that's what you were asking, right? You can find me,
or where people can learn more about your practice, or if they wanted to get a consultation with you.
Yeah. So the easiest way is probably to email me through my brown email. It's Petra_Klinge@brown.edu.
Okay.
And they can send a request, and my staff is happy to share, like stuff that we're doing, and also can initiate a consult. That's the easiest way. The next research that we're doing, and we actually probably in March are starting to recruit patients, is the proof that the phylum, in fact, controls all the paraspinous muscles from the bottom up to the neck. We call it the Spinal Cord Motion Project. So what we will do is we will, at Brown University, in our Center for Innovative Research at Brown, we will ask patients if they are willing to come to the center before tethered cord surgery. We will do like surface EMG electrodes, not needles, surface stickers on the entire spine, and have people, for people with tethered cord, have people walk and do certain chores, and then we record the synchronized activation of the muscles along the entire spine. And we hypothesize it's going to be desynchronized in people with tethered cord syndrome. And then we will offer the tethered cord surgery, of course, and then we'll redo it after the tethered cord surgery and see whether the muscle activation becomes synchronized again. And if that is the case, we have the proof of the concept that really our phylum is, like navigating our entire spine. And if it's a bad phylum, it's messing up, with the coordination of the muscles and the spine. And that's what causes scoliosis, kyphosis, back pain. So that is our project, the Spinal Cord Motion Project. That is the next step of our research, to really understand the whole concept of it. And also get evidence that that's what the surgery does, correct the spinal biodynamics.
That's fascinating. So you're saying that the diseased phylum may contribute to scoliosis? Your hypothesis in this okay. Oh, wow. Very good.
And also kyphosis and abnormal alignment to the spine, and muscle weakness, of course, and back pain.
Fascinating. Well, we will all be staying tuned, and I hope you'll come back and talk to us about that research once. I'm sure it's going to take a while before that project is completed. Research always takes quite a while, recruiting all the subjects.
Yeah, that's going to take a while,
and then,
yes.
Analyzing the data and all of that. So, but thank you so much for chatting with me today. I really appreciate it. This is such an important topic. So many people with these conditions are impacted by tethered cord syndrome, and it's complicated. It's not like you just go get an MRI and you definitely get your diagnosis. So I really, really appreciate you taking the time to chat with me today.
Thanks for having me, Dr. Bluestein. I really appreciate your time, and I hope it helped. And I will also be very happy to share with Shanti the links to some of the publications that I mentioned.
Great.
Because I do also hear from other patients that when they read it, it helped them a lot to feel validated and to believe in the problems, and to not give up on themselves, because that should not happen.
Yes, absolutely. Absolutely. Yeah, if you're able to do that, that would be great, just to make sure that we've got the exact right papers. And so, thank you again. This was really fascinating, and we'd love to chat again sometime. That was a fascinating conversation with Dr. Klinge. She is such an amazing and wonderful neurosurgeon. And so I think it's really great that we got to have this conversation about such a nuanced topic like tethered cord syndrome. I really hope you enjoyed this week's episode of the Bendy Bodies with a Hypermobility MD podcast. You can help us spread the word about joint hypermobility and related disorders by leaving a review and sharing the podcast. This really helps raise awareness about these complex conditions. If you would like to dig deeper, you could meet with me one-on-one. Please check out the available options by visiting the services page of my website at hypermobilitymd.com. You can also find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, and LinkedIn at HypermobilityMD. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can find full video episodes up every week on YouTube at Bendy Bodies Podcast. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a human content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.